We start in about 50 minutes. Okay, we start in about 30 minutes. We start in 20 minutes. Good morning, Harshad. Good morning, everybody. I had to turn out the sun. The sun is too strong here in Miami at 8 o'clock in the morning. Good morning, everybody. I had to turn out the sun. The sun is too strong here in Miami at 8 o'clock in the morning. Hello, Arshad. Are you there? Hello, Arshad. Are you there? Hi, Dr. Liao. Are you there? Dr. Liao, are you there? Excuse me for the coughing. Hi, Dr. Liao, are you there? Dr. Liao, are you there? Excuse me for the coughing. Hello, Juha, are you there?
Hello, John.
Good
How are we
morning.
doing? Good evening from here.
Okay. How you doing today?
Okay.
Busy day?
Not busy.
No. Okay, still waiting for Fady to come.
Hello, Juha, are you there?
Hello, John.
Good morning. Good evening from here. How are you doing today?
Is the COVID the same there?
Okay. Busy day? Not busy. No. Okay, still waiting for Fady to come. Hello, Juha, are you there? Hello, John. Good morning. How are you doing today? Is the COVID the same there? Busy day? Not busy.
Mm.
Still waiting for Fady to come.
Hi, Dr. Liao, are you there? Okay. Mhm. Juha, how's the COVID in China? Still the same?
China and about the Delta variant, so they increased the restrictions heavily. So, for example, my center has had no activity last week and this week, but maybe next week we begin again.
Oh, so lockdown, everything's locked down?
This is different. In China, you have 100 cases in the whole country, 1,410 million people, and then you
Wow.
close everything, heavy restrictions. And now today there were only 33.
Oh, wow.
Maybe next
So
week.
already
everything-
from those restrictions, already it's going down.
By 100, it's going lockdown,
Wow.
really.
The United States, there's still pockets where people don't want to get vaccinated. 99% of the new cases are people that don't want to get vaccinated.
Mhm.
So that's a problem. I get some places in the United States you have to, companies will say you have to get vaccinated or you're fired.
China is obligatory vaccination. You cannot
Good
refuse.
morning. How are you, Dr. John Bennett? How are you?
Good morning, Saeed. How are you, Ben? How you been?
Vaccination.
Very well. Thank you very much.
How are you're in Algeria, right?
Yeah, Moroccan. I'm in Marrakesh city, Morocco.
Oh, Marrakesh. You're in Morocco.
Yeah.
Oh, okay.
Actually, we cannot. In fact, we cannot.
There's Dr. Z.
Yes, Professor.
How you doing?
Yeah, we are cleaning commercial advertisement here all the time coming from China. So
Really? On the channel, our channel?
that they are coming up they are coming on the screen of laptop all the time. So we clean them.
Oh, okay. So Z, we see you there.
Q1, you mean?
Okay. Oh, Takashi's here. Okay. Victor Hugo's here. Me.
Hello, how are you?
Good morning, Victor.
Good morning, dear Professor Juha.
Hello, Victor.
Hello, Takashi.
Hello, Takashi.
Good evening.
Yeah.
Good morning,
Good evening.
Katashi.
Good evening. Good evening from here.
Here's Ben. Here's Ben. Let's see.
Hi, John.
Good morning, Harshad. How are you?
Good evening, good morning. I'm fine. How is Professor Juha?
We are fine. We are fine. Thank you. Hello, Bill.
All well.
Hello.
Hello, Victor. How are you?
Hello,
John.
how
Hello,
are you?
Juha.
Hello,
Arshad?
Victor. How are you?
Hi.
You?
Hello.
Hello.
Hello,
Good morning,
Takashi.
Ben. Good morning.
Good morning.
Good morning, Ben.
Good evening. Ben.
Good morning, Takashi.
Good morning. Good evening. Here in Japan. It's 9 p.m.
It's evening in India. It's evening in
It's
India.
evening.
Yeah.
Oh, evening, India. Okay.
India, yeah. It's 5:30 p.m.
5:30 p.m. It's
Yes,
9
yes.
p.m. in Tokyo,
Tokyo. Okay.
Tokyo, Japan.
Yeah, this is a good time, except for California and all the world, except
Mm.
for the Western United States.
Mm.
It's like 3 in the morning there. It's very early.
Mm.
Okay. Oh, fat. Have you talked to Fady lately, Juha?
Yeah, I have been connecting. He said we will meet soon. Sent him the link, so he should be here.
Okay. We have a few minutes. Good morning, Giancarlo Pera from Italy.
Sicily, Tangallo, Palermo, our good friend since many years. Hello, Giancarlo. You're muted.
Hello, Giancarlo.
Oh, Louis Ebor, great.
Good afternoon. and good morning.
Hey, Louis, how you doing? Welcome.
Hello, Luis. Hello, Luis.
Hello,
How are you
Luis.
doing?
Hello, Luis.
Well, I am very interested from this topic today. I like this.
You're relaxing today.
Yes. And you, John?
You're in the hospital, not in the hospital, right?
No, in home.
Yeah,
In home.
At home, okay.
I am in holidays.
Oh, okay. At the farm, you're
Only 3 weeks, but it's better.
okay.
Buenos días, Takashi.
Buenos dias, Dr. Luis Lopez.
I'd like to hear Spanish with a Japanese accent.
Yeah, I'm studying estudio español.
Yeah, you are better accent to John.
Okay, yeah, I learned. I've learned.
Where is Fady?
Okay, it'd be a minute or two, I guess. Oh, here's Fabby. Here's Fabby. Okay, very good. Good morning, Fady.
Sorry, I realized I did not have my video on. Good morning.
I'm John
Good
Bennett.
morning, Fady.
Nice to meet you.
Fady,
And you know
welcome.
Juha, of course.
Since many years.
Okay, are you ready to go? Are you comfortable with the Zoom platform, Dr. Charbel?
Hard to not be comfortable.
Oh, have you screen shared before?
I have.
His experience.
Oh, okay. We're ready to start, right?
Ready to start.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have the pleasure of having Dr. Fady Charbel from University of Illinois, and I'll let Juha give a proper neurosurgical introduction. Good morning, Juha.
Hello, John. Hello, everybody. Welcome, Fady.
Good morning. Morning, you. Good morning, everyone.
Can you see it? It's okay?
Yes.
Okay. Welcome, Professor Fady Charbel from Chicago, University of Illinois, USA. He's certainly one of the most important neurosurgeons of these times in the world. Professor Fady Charbel is Lebanese, like many of the outstanding prominent neurosurgeons working in USA. He studied medical science in Beirut and finished 1984. After that, can you take that sound away? So he finished his medical studies 1984 in Beirut and then switched to USA, where he had his neurosurgical training in Detroit and Montreal. And after fellowships, 1991, he has been working in Chicago, University of Illinois, and his present position since close to 20 years is as a professor and chairman. How to become a good neurosurgeon? I always ask this question. Yeah, have good role models, train hard, and follow the way Professor Fady Charbel is doing. In neurosurgery, there are different levels of manual skills. It depends on number of repetitions and length of career. There's an old regular rule of 10,000 hours of training. With this training, you will come to the top of the world. And my rule is that with 10,000 days in operation room, you are at your best of your neurosurgical career. Neurosurgery has three parts: operative skills, which are certainly outstanding by Fady Charbel. There's research, clinical and basic. He's doing a lot of innovative clinical research, has been teaching a long time, involved in many congresses, training many residents, fellows, neurosurgeons at home and abroad, has given big number of webinars and has been involved in live courses, also in Helsinki that time when I was there. Professor Fady Charbel has specially made bypass surgery to be based more on facts than beliefs and myths. Professor Fady Charbel has extensive number of publications, and one of the most famous innovations around the world is the Charbel microprobe to measure the flow. Then he has the Canvas computer-aided neurovascular analysis and simulation. Professor Fady Charbel has many innovations in medical devices, diagnostic imaging, as well as surgical simulators. He has many patents, more than 10, and recently has extremely wonderful cadaveric and experimental laboratory where he can give courses for a big number of neurosurgeons in training and specialists. He has many awards, and the most prominent is the Cushing Award in USA. He's training best young people to become better than we are. And this is extremely important principle, lifetime learning, lifetime teaching. So I thank you very much. Kiitos, KK. So please, Professor Fady Charbel, give your webinar on the posterior circulation revascularization. We are waiting for this excellent lecture. Please.
Thank you very much, Juha, for this kind introduction. And I'll have a few words to say about Professor Juha Hernesniemi, who is an idol to many of us in a few moments during my talk. I will just start by saying hello to the many, many people that I see on the screen. I see Professor Pera, so good to see you, Giancarlo. After all those years, we met so many times at Professor Hernesniemi's course in Helsinki, around the world, and it's wonderful to see you. I see Professor Shubin, top world leader in bypass surgery, nobody like him. It's hard to recognize everybody, but it's great to see you. I will share my screen now. And start the presentation. It's good.
Perfect. Perfect.
Great, thank you. So the topic that I chose today with discussion with Professor Hernesniemi, Juha, is the evolution of bypass surgery for vertebrobasilar insufficiency. It's a topic that will go over my journey of progression in knowledge-based application for this disease over the years. Before I start, here are my disclosures. I do not have any financial interest in the NOVA software, which measures flow with MRI, and I am a consultant for the Transonics company, which develops the flow probe. But before I start, I would like to take a moment to say a few words about Professor Juha Hernesniemi. I said some of these words recently during a tribute to Helsinki Neurosurgery course, which was held by Professor Hernesniemi for many, many years, and which truly was the #1 primo live surgery course. Thousands of people came around the world to come and attend Juha in Helsinki. I first met Juha there in Helsinki many years ago, and it was at the occasion of being the opponent of a thesis, PhD thesis of one of his trainees. I had for a long time wanted to go and see Juha in his element. I had seen his presentations, his surgeries. Everybody knows how much of an amazing surgeon he is, but I wanted to see him in his element. And if I were to say that there may be top 2 or 3 moments in my life where that changed my view of neurosurgery, this would be in the top 2 or 3 of them, is meeting Juha Hernesniemi. Why? The reason why is, I think, best summarized in what I'm going to say next. Any one of you that spends time to understand Finland as a country and Finland as a people, and I'm certainly not an expert in that, but I am a big fan, will realize that what happened in that department in Helsinki, as embodied by Juha, and the spirit that he put in that department and how he was able to achieve the things that he achieved, are summarized somehow. He crystallized all those qualities. And what are those qualities that I can talk about? The first, you hear the concept of simplicity. Juha's surgery is simple, but it's not easy. It's like the Finnish language. There is a mastery that comes from simplicity and from being fast, but being fast is not moving quickly. It's really having thought about every step of the surgery and reduced it to the least essential steps, and that is what you learn from watching Juha Hernesniemi. The second thing is you have to understand that you don't get to be Juha Hernesniemi without having an inner sense of fortitude, ability to move forward despite all odds. And all of us face odds in our life. And in Finland, I learned this wonderful expression, sisu. It's indescribable, really, in the English language, but it has to do with inner strength and moving forward. I learned it from Juha. He mentioned this many, many times to me, and it's, I think, a true representation of his self. And the last one is pride and identity. Rightfully so, Juha Hernesniemi is a proud man, and he deserves to be a proud man. He has a sense of identity. He has carved from himself a path with many followers, and I think everybody recognizes when you see a video from surgery that it's Juha Hernesniemi operating. So he has a very strong sense of identity, and all these together, I think, represents many of his contributions. So it is my tribute to you, Juha, a great role model for me and for so many people around the world. I greatly appreciate everything you've done for neurosurgery and your personal friendship. This is our campus, the University of Illinois at Chicago. It's a large campus in an urban area. You see it expands over here. And that star is our institute. It's called the Neuropsychiatric Institute. It's a very interesting building. It was completed in 1941, and it was constructed to resemble the brain, with two towers that are like the hemispheres and the corpus callosum in between. And this is where Majid Sami got the idea of having the institute that he built. Of course, it's more modern and it's more beautiful, but that's the idea. It was the first in the world to look like that. The first head of the institute was Eric Oldberg. And Eric Oldberg was the last resident of Harvey Cushing, a very important figure in neurosurgery at the time. And he was a chair for a long time in Illinois, for 30 years. This is the operative book that I have in my office. The first surgery was done 2 days after Pearl Harbor, which is Tuesday, December 9, 1941. And the surgery was done by Oldberg, and he was assisted by Dr. John Green. He was his resident. John Green then went to Arizona and founded the Barrow Neurological Institute. After Oldberg retirement, he was succeeded by Dr. Sugar and then Robert Kroll. And this is another very important man in my life, Dr. James Ausman. Dr. James Ausman is a towering figure in neurosurgery, a innovative man, very strong personality, extremely smart, and always thinking ahead of his time. He had an immense influence in my life, and I'm extremely grateful to him forever. Dr. Ausman was not only a superb neurosurgeon, he had a keen interest in vertebrovascular disease and pioneered many surgeries, occipital to pica bypass, STA to SCA bypass, ICA bypass. And when I trained with him in Detroit and then came with him to Illinois, the focus on innovation in cerebrovascular surgery certainly was greatly spurred by him as a unique role model. So this is our institute now. It has grown many buildings like everywhere. And this is the lab that Professor Hernestiemi was mentioning, that's at the bottom of our institute. It's a beautiful lab that we just finished, and it's focused on innovation and training. And you see here the pedigree of the various people that were associated with this to get us to this day. We really look forward to seeing you there. There's the typical training areas in the center. There's large operating rooms, full operating rooms on either side. It's a very nice building with natural light and natural plants and technology with screens that change color and so forth. And our residents have done a fantastic job organizing courses there. And we really cannot wait for travel to resume so that we can have you, Juha, there and many of our friends there. Happy faces of our residents there. It's really, Juha is absolutely right. As we progress in our training, the greatest joy that I have is seeing these outstanding young women and men that you have so much affection for. You see them blossom and become themselves, become the full expression of who they can be. It's absolutely rewarding, most rewarding thing. I would also, of course, like to acknowledge my colleagues in the cerebrovascular team by alphabetical order. Ali Alaraj is the head of the neuroendovascular section. Seppi Henjani, everybody knows Seppi, fantastic researcher and surgeon, co-leads the section with me. Gursant Atwal, a rising superstar in both open and endovascular neurosurgery. And our fellows, I mentioned only those three because they're involved in some of the material that I will show. amazing individuals that come and spend time with us, and they all have gone on to have fantastic future careers in very big major institutions. Matthew Koch, Alfred C., and Chris Stapleton. Absolutely love these guys, phenomenal individuals. So the talk about this vertebrobasilar insufficiency from evolution of the recognition to technique is a personal journey. So everything that we'll talk about is based about my experience and what I learned from it, and hopefully you will find this of benefit to you. This is the case that started really the deep thinking for me. I was a resident in Detroit with Professor Ausman, who, as I mentioned, had a big interest in basilar disease, and this man came to us. He had bilateral vertebral occlusion. He had some filling going down his basilar. There was a stenosis here, and Dr. Ausman put us all together on a Friday, and we all thought about what should we do. We had many options. We selected one. We operated on the man. It did not work. I actually did the autopsy myself on this man to learn, and you see the plaque here in the basilar system. Look how diffuse this plaque is. It goes up. It flows through many branches. Very difficult to treat. We tried to approach it through a transclival endarterectomy. It was a very difficult surgery, and it did not work. So I thought, well, maybe what we should do going forward, let's see if we can find a way to predict what will happen before we do it. Wouldn't that be nice? So I started this experimental setup where I would have fresh brains. Unfortunately, in Detroit, there was a lot of crime, and young people sadly would be dead in the morgue and nobody claims them. So we could have access to fresh brains on Monday morning after a busy killing weekend, sadly. And we did experiments. So I go to the lab and I did this setup where I reproduced vertebrobasilar ischemia. You see here a stenosis with this tie. You see the basilar, the posterior communicators are clipped. Here's the third nerve. I have a needle here with a pressure sensor in the ICA, and I have a flow probe around the basilar, and I create a stenosis and see what happens to the flow and so forth, and do a bypass and try to understand the dynamics of the surgery. And here's what you can expect. Here's the flow probe on the basilar, stenosis being created. We're measuring pressure distally and proximally. And you can see that as I tighten the stenosis, the distal pressure after a point starts to drop and the flow drops. And here's the proximal stenosis. So the pressure gradient drops and the flow drops. And then I do the bypass to the PCA, and here's the flow. And when I open the bypass, notice what happens. This is really important and unexpected. The pressure, the distal perfusion pressure, improves dramatically. It goes up. But the flow in the basilar decreases. So in fact, this bypass not only did not help, actually made things worse. So sometimes, this is the first time I realized that sometimes bypasses can produce an undesirable perturbation in the vascular system. I couldn't believe it first. And I went and showed it to Dr. Ausman. I said, Dr. Ausman, what do you think? He says, well, you know, that's very disturbing. You have to repeat the study. So I repeated it many times. And it was always the case. You improve the distal pressure, you drop the flow. And the proof is that when you close the bypass, the flow actually improves again. It's still low, but it's better. The answer, of course, is that by doing this, I have changed the pressure gradient. I have reduced the delta P because the pressure distally is not low anymore. It went up, and that low pressure was driving the system. So the first lesson here is that flow and pressure do not always go in the same direction. And there's a lot of people nowadays that look at pressure, they put pressure needles in vessel, and they measure pressure, and they put a bypass, and they think that the pressure went up, this is good. Well, sometimes it's good, and sometimes it's bad. Depends on the territory. So you have to really measure flow. And I wrote that down, and that was a long time ago. And you can see right here in red what Dr. Ausman said to me. Excellent, Fady. And what I wrote is flow is generated by a pressure gradient, which is obviously a very straightforward thing. It is generated by pressure gradient. So if you change the pressure gradient, you will change the flow. Sometimes it's a bad thing. And the other thing that I wrote is that when you have an isolated posterior circulation, this is a true hypoperfusion problem. And what you have is a zone of no flow in the middle of the basilar where there is no gradient of pressure, especially if there is posterior communicating. You have competing flow. And that can be a real problem, and that could be the problem why patients can have these recurrent hemodynamic symptoms. So that was the hypothesis, and this is now 30 years ago. And that is a lot of work that went on. So this is one of the reasons I went to Illinois, to be with Dr. Ausman, of course, and to be with the engineering group there, because University of Illinois is world famous for engineering. We founded this group. We still work on that, on computational and flow analysis. And from that, we developed the flow probe, so we can measure flow at surgery that Juha mentioned. And this is the NOVA system, which came later, which is the ability to measure flow non-invasively with the MRI. And this, you can do it in the MRI suite, but in some places like Professor Shubin, they have it actually in their MRI in their hospital, one of probably the only place in the world where they have that. And we learned a lot of things. And I will just briefly mention that because of this, when I wrote this paper back then, it was to really stratify the aneurysm, the bypass. That bypass is done really for only one of two reasons. We're either trying to augment flow for ischemia or preserve flow if we injure a vessel, like in a bypass for aneurysms or tumor. There's really no other way to think about it. It's algorithmic. And if you think that way, this is how you follow the simplicity model and clarity model that I mentioned earlier about Professor Hernisnian. You have to be clear, but clarity comes from a lot of thinking beforehand. So later, this is the second case. This is about 10 years later. This patient comes to me. I am now a younger attending and has strokes in the posterior circulation that you see here. Pons, peduncle, occipital lobe. He's very hemodynamically unstable. Whenever we lower his blood pressure, he becomes almost comatose. We do an angiogram and we see this mid-basilar stenosis, just like the model that I did in the laboratory. So Gerard de Bruyn, who's the father of neuroendovascular in the Western world, was our faculty. And Gerard said to me, Fady, I do not, at the time, I do not have a tool, a proper tool to do an angioplasty. The balloons were too big. He didn't have a tool. He says, do a bypass and maybe then I will try an angioplasty. So I did, but I was very worried based on the work that I done in the lab, that if I put a bypass here, I'm gonna abolish the pressure gradient and there will be no flow. So I'll improve the pressure here, but now the pressure here is equal to the pressure below. And because of the stenosis, it will not flow anymore. But I had to do it because this man was getting worse. And you see here the STA to PCA bypass. Here's the angiogram at surgery. It was Friday. Monday morning, this man had a sudden deterioration and the angiogram shows that the basilar occluded. So I rushed him to surgery at the time. Here's the angiogram, basilar occluded, and I attempted to open it. This is a transclival approach, drilling the clivus, exposing the basilar origin, VB junction, and you can see his basilar clot was so high that I could not reach it. I've drilled all the clivus, and you see here only the beginning of the clot in ICA. It was very, very high. So I closed it with a fascia lata patch, and I turned the patient, and I went pretemporal, transtentorial. This is the carotid. This is the third nerve. And I tried to do an angioplasty. You see here, I have a rubber dam around the basilar. Now you see the clot in the basilar below the third nerve. And I tried to do an angioplasty like this, but you see how huge this balloon is. We did not have the technology back then. So then I proceeded, I could not do it. Here's the clot, the thrombus in the basilar. So I did an endarterectomy of the basilar. Now, from the supratentorial approach, transtentorial, you see I removed the clot. Here's the plaque. And I removed the plaque and I stitched it successfully this way, but I could not keep it open. Why? Because the surface is raw. So this is the only, but the patient actually did okay because of the bypass. She survived. This is now 10 years later. She's still alive till today. Look at the bypass, protecting the top of her basilar. She had a deficit, but she improved. This is now even later. You see now we're measuring flow in the bypass, and you see that this bypass has 91 cc's of flow. This is the only person, I have not actually published that, but this is, I believe I'm the only person who's done a basilar endarterectomy on a patient who actually survived. So then later, another lesson. So what did I learn from this one? I would say there was a success because she's alive. It was a failure because I could not open the basilar. So it was mixed. The first one, of course, was a failure. Here's a third lesson. Same problem, different pathology. Comes in with a giant dolichobasilar ectatic aneurysm. You see the aneurysm, mass effect, ataxia. So how do you treat this? It's a very difficult problem. One way to treat this is to change the flow dynamics. So I did that on purpose now, having learned what I learned. I put a vein graft to the top of the basilar, and I did that on purpose to reduce flow in the basilar artery, now that we know that this actually does that. So it looks good, except that the patient started to deteriorate clinically. No stroke, bypass is patent, fully anticoagulated, but over a period of months, he gets worse and worse and worse and worse, and finally, he becomes stupors. And what's the problem? Well, the flow in his basilar, right here, you see where we're measuring it with the NOVA software, it's an MR, shows the direction is going up towards the head. The flow is 49, which is low, and I like that, but there was something here that I did not recognize until later. Look at this waveform. The flow in this basilar artery with every heartbeat goes to below zero. Actually, it stops here, stops here, stops here. This is the flow every heartbeat. This is highly abnormal. This should never happen. And this is the same setup that was in my experimental model that I showed you in the beginning. With every heartbeat, there's competing flow, and there's pauses of flow in the basilar artery, which produces ischemia, repeated micro ischemia. So I thought, if that's the problem, how about I occlude the vertebral arteries from below, and now the flow comes from the top. And here's actually a representation of this. This is not simulation, this is real flow measurements with the NOVA. Before the bypass, the tall one is the carotid. This one here is the basilar, and you see how they're flowing synchronously at the same time, up and down, up and down. This is a lesson in physiology. Look at the sagittal sinus. You see the flow in the sinus is in diastole, and the flow in the carotid and the arterial system is in systole. But very importantly, the flow is always positive, and it's always integrate in the brain. It's not like the rest of the body. After the bypass, here on the right, the carotid still looks good, but look what happened to the flow in the basilar. Every time the flow goes up, blood goes up in the carotid, goes down the bypass, it pushes the basilar flow down. So this counteracting flow is causing a harmful effect on the basilar circulation and producing ischemia. So what did I do? I closed the vertebral from below. Now the flow is the same, 47, but it's minus 47. It's reversed. It's going down. And guess what happened to the patient? He woke up immediately. In fact, he woke up on the MRI table. He was ambulatory the next day. 6 months later, the aneurysm thrombosed, but he has a beautiful bypass filling his system down the ICA, and he's done beautifully. And he remains well many, many years later. This is not a new case. Look how much flow is in this bypass, 182 cc's. That's the full flow of the basilar. So what did we learn here? Later, I was giving this talk at an engineering meeting, and there was a young man in the room who was doing a PhD in England, and he said to me, I have an explanation for this, because he was working on this on his PhD. And he said, this is called cessation of diastolic cerebral blood flow velocity. And remember that picture that I showed you? And I said, there is no flow right here. Flow comes from above, flow comes below, and then interruptions. Actually, he proved it. That was part of his PhD thesis, and he sent me the paper. So smart people may have the answer somewhere for a problem you are struggling with. And why did we not see it? Well, because we don't think about it. You all know the story. This is a man looking for his keys. He dropped his keys over there, but he's looking for them here under the light. That's a classic picture. Because when asked, he said, we search where we can see. And if we don't have a way to answer a question, sometimes we don't ask it. But still, the question is to be asked. So over time, then, we developed tools to understand vertebrobasilar ischemia, and that was because of the NOVA software. We understood that this system is actually a very simple system. It has 2 inlet vessels, the vertebral arteries, 2 possible inlets, which are the PCOMs, and 3 target vessels, the posterior cerebrals and the basilar artery. And we have normal flows for these, more than 120 for the basilar, more than 40 for the PCA. We've published extensively on that. And if this is compromised, you have a low flow state. And if you have a low flow state, then flow augmentation procedure is indicated. But if not, it is not indicated. We published that in Stroke on a retrospective study, cover of Stroke. And then my colleague, Dr. Henjani, led the study, this NIH study, which was a landmark study, Veritas it is called, which demonstrated that patients with low flow state have a much higher risk of stroke than normal flow state. 22% versus 4%. So it's a very strong predictor of stroke in the posterior circulation. It's the only study of its kind that was done for this. It's probably the only study that would ever be done about this based on the software that we developed. So now we have a tool that can determine low flow state. And now that we have a tool, we have an amazing number of opportunities to help patients with low flow states compromise in the vertebrobasilar system. I'm going to show you examples of those now surgically that go all the way from the origin to intracranial. So here's the first guy, strokes, pons, cerebellum, occipital lobe. He has a vertebral origin stenosis, 90%, and he has a low flow state. Again, what's the definition? Basilar, below 120, PCAs below 40. He has definitely low flow state with symptoms. So there's many options to treat vertebral artery stenosis, including endovascular option. But for this disease, the surgical option and the best option is this surgery, the vertebral to carotid transposition. It is much better than a stent, much more durable. It's an excellent surgery. And the approach is supraclavicular. The vertebral lays in a triangle that has its apex at C6. Usually the vertebral artery enters there. There's variability, of course. You have the longus colli and the scalenus anterior. So it's a triangle, and you go between the carotid and the jugular and you perform a vertebral to carotid transposition. Here's the surgery, supraclavicular incision. Here's the common carotid artery is exposed. Here's the vertebral artery is exposed. And you see we're passing a loop around it. Here's the vagus up here. The flow is only 15 cc's in this vertebral. Notice right here, the sympathetic chain. You have to be careful with that. And you have to be careful with the thoracic duct. So I'm cutting the vertebral artery after ligating it proximally close to the subclavian. And I'm going to slide it from the chain. Now, this big thing here is the thoracic duct. You either gotta cut it, ligate it, or leave it alone. See the thoracic duct right here? Can you see my marker? Hopefully you can. So the artery is fish-mouthed. The common carotid artery is clamped with this clamp that's called the Satinsky clamp that allows you to rotate it, because the anastomosis must be performed on the back wall. Otherwise, it will kink or it will not reach. Notice the thoracic duct right here. You have to be very careful with it. If you injure it, you'll have a lymphatic leakage, which is a very difficult problem. That's the jugular, the vagus nerve. The clamp is being removed proximally and distally. You can check the flow. Now it's more than tripled, 51 cc's. And here's the vertebral to carotid transposition and the thoracic duct that is intact. It's an excellent surgery. It is much better than stenting for this disease. And here's the angiographic result. And did we improve the flow? Yes, we did. Basilar artery improved. PCA is above 40, which is normal flow. Now here's another patient, similar problem, strokes. You see the vertebral artery that is very narrow here, the other vertebral artery that's occluded. You see here, which is very important, the flow in his basilar that goes from the PCOM, but look at this pattern of flow here. Remember, I talked to you about this oscillating flow. So his flow is low, very low, only 4. And look how it's oscillating. This man has a very, very severe hemodynamic problem in his basilar system. So this is what I did for him. I did a vertebral to carotid transposition, but there was a little twist to it. And the twist is because this man used to be a very strong bodybuilder, and his muscles are enormous. He had a huge, huge neck. Look how big, this is his sternal portion of his sternocleidomastoid. Look how enormous this is. Huge muscle. So we had to deal with that. And as a result, the vertebral artery was extremely deep. So that's the approach. It's on the left side. The yellow loop is on the vagus. The blue loop is on the common carotid. So the carotid is retracted medially. That's the jugular vein, retracted laterally. And at the depth of the field, you see the vertebral artery. But this is very deep. I'll show you the video in a little bit. So what I used here is the vertebral vein. This has never been published before. We're about to publish it. Below the transverse canal, in the V1 segment, the vertebral is actually a vein. After that, it becomes a plexus. So this vein exists. Here it is. I am marking it because I used it. Here's the vein. So I cut the vertebral vein. It's a nice size vein. And here's the flow in the vertebral artery, 40, very low. And I put a vein graft between the vertebral artery and the common carotid artery, so this way it would reach. Otherwise, it cannot reach. And you see the ICG into cyan and green, and here's the picture. And look at the flow. It went from 40 to 124, 3 times more. And here's the picture, a vein graft going to the vertebral. And here's the flow going to his basilar, which improved dramatically. And look at the waveform. It went from this oscillating up to 0 to a much normal waveform. So I'll show you a little bit of this video. You saw this here. Now, what is important is for you to see this. Look at the flow in his basilar. Look how it goes down and up and down and up. I don't know if it's playing. Well, you see it doesn't oscillate on this photo, but it does normally. So here's the surgery being performed. That's the vertebral artery. Down here, the vein graft. I already showed you all this. So it's a way to solve this problem if you have a deep neck and you need an interposition graft. Now here's a more complicated problem because there's a vertebral artery stenosis at the origin and distally. So there's tandem stenosis with a low flow state, below 120, below 40. So how to treat this? First step is vertebral to carotid transposition. And now the endovascular team can access the vertebral through the carotid, and they can go up to the stenosis, they can stent it, and we solve the problem that way. So a lot of variation, but the surgery is a fantastic option. How about the mid segment, the V2? The pathologies here usually are compressive. Often it's a bone spur, like this man. You see a very tight compression that you can remove with direct access. So here's such case. Look at this man. He has vertebral artery stenosis with his head straight. When he turns his head, it occludes completely, and he has a stroke. And here's the problem. You see this massive osteophyte right here, massive osteophyte. You cannot see the vertebral artery. And this vertebral artery has very little flow in it, and it's embolizing into his pica, and it's causing him symptoms and recurring stroke. So that's the setup at surgery. Direct approach to decompress the vertebral artery. And if it doesn't work, I would do a Carney bypass. I'll explain to you what a Carney bypass is. It's a radiolucent frame for intraoperative angiography. Lateral approach, that's the jugular. In this case, the approach is between the sternocleidomastoid, but lateral to the jugular. Here's the picture, lateral to the jugular vein. Here's that big osteophyte. You see the vertebral artery. I've already decompressed it somewhat, and now we're reaching the osteophyte, very narrow stenosis. Look at the flow. It's only 3 cc's. And then I'm drilling the osteophyte, and after decompressing the osteophyte, the flow goes up almost 20 times, 67. And see, the osteophyte has been removed. Here's the vertebral artery, and now it looks quite good. And there's a video of this, but maybe the videos don't run very well. Maybe they do. Here you see a little bit of the osteophyte being decompressed, and here's the vertebral artery. Here's another one. Now this is a very interesting one. This lady has radiculopathy, has a arm radiculopathy. She was thought to have a herniated disc. They did an MRI on her. There was no herniated disc, and they couldn't understand why she had a radiculopathy. But look what her compression is caused by. She has loops of redundant vertebral artery exactly at the C6 cement foramen, which was the exact location of her radiculopathy. So how to treat this? Same way, decompression. Look at the sympathetic chain here. We have preserved that. This is the loop of the vertebral artery. So I've unroofed the transverse foramen of C6 and C7. This is before, this is after. See how the vertebral artery moved laterally and her radiculopathy resolved. This was very important for her because she was a violinist, and that's her right hand. And she was very happy that we fixed her problem. It was not recognized otherwise. So you have to think outside of your element. A vascular neurosurgeon would not have recognized this problem. So again, that's pre-op. You see the compression, and that's post-op. And you can see the decompressed C7 nerve root right here. What is the Carney surgery? Carney operation. This is Dr. Andrew Carney. Andrew Carney is a retired thoracic surgeon, but he had an interest in the vertebrovascular system. He wrote this book. Him and his wife, who passed away, Evelyn, had a great interest in cerebral hemodynamic. He was a great influence on me. I got to know him when I moved to Illinois, and I learned to do the surgery from him. Carney operation, which is a carotid to vertebral artery at C1, C2 bypass. This is the Carney operation. It's a lateral approach to the vertebral artery at the C1, C2 junction. You see the vertebral artery at C1, C2. And after you cut the ramus of C2, you expose the vertebral artery and you can connect a conduit. Now, I've seen the videos of Dr. Carney doing this surgery when he first published it. in the 70s. He did that anastomosis with silk sutures, without loops and without a microscope. Now that is amazing surgical skills. Nowadays, of course, we use a microscope and we can do the surgery a lot easier. We have all the tools. So here's the approach. I'm cutting. So to orient you, the bottom of the feet is to your left, the head is to your right, medial is to the top, and lateral is to the bottom. So we're placing a loop here. I'm feeling for the tubercle of C1 right here. That's the tubercle of C1. That is the 11th nerve, accessory nerve, that's going from medially to laterally, and it will end. It will not end. It will go into sternocleidoid on its way to the trapezius, of course. Here's a vessel loop on the occipital artery. You see the vagus right here. We're isolating everything. And here's the anatomy. You see, starting from the bottom, the jugular vein. You see the ansa cervicalis that goes up, joins the hypoglossal nerve. Here's the occipital artery right here. Here's the accessory nerve that goes into the sternocleidomastoid and the levator scapulae. And right here is the levator scapulae that is being disinserted and cut because that's going to be our window to C1, C2. Again, accessory nerve, vagus nerve, and that is the tubercle of C1. And once that is identified, sometimes it's helpful to take an X-ray. So you can put a clamp on it and take an X-ray, a lateral X-ray, to really identify that that is the tubercle of C1. And be sure of where you are. You see the clamp on the tubercle of C1. And once that is done, you can dissect between C1 and C2 and identify the vertebral artery. This is the anterior ramus of C2 that is cut and reflected anteriorly, not posteriorly. That's important. And once it's reflected anteriorly, you have a window into C1, C2, and here's the vertebral artery that's surrounded by its plexus. And what you do from there on depends on the anatomy. So what can you do? Here's a man that every time he wants to go out of his driveway, he turns his head to the right and he passes out. He has a syncope. Why? Because he has multi-stage stenosis and occlusion of osteophytes that occlude his vertebral artery when he turns his head. So how to treat this? He also has a carotid artery stenosis. So how did I treat this? I did both an endarterectomy and a carny at the same time. Is the carotid exposed, the endarterectomy is completed, and here's a vein graft from the common carotid all the way up under the sternocleidomastoid to C1, C2 right here. And here's the result. Now he has a carotid trifurcation, not bifurcation. So is the common carotid, the external carotid, both are open. And he has a vein graft that goes from the carotid to his vertebral artery, which totally fixed his symptoms. And here's another one. All the things that you can do with this operation. Tandem stenosis, proximal and distal. It was fixed with a stent, the distal stenosis. The flow improved, like you can see here. But then the flow dropped. What happened? Well, the proximal vertebral artery occluded, and this restenosed. Well, how are you going to fix this now? Well, how to fix it is with a carny. So I put the conduit here, common carotid to vertebral artery, pass a catheter through that, and now endovascularly, the stenosis can be fixed, and the flow is improved. We've used this many, many times in many different settings to access aneurysms, to do all sorts of treatment. It's a very useful thing to have in your surgical armamentarium. The V3 segment, I will not go over that. You can do some revascularization, occipital to pica, occipital ICA. The more you go distally, the more, of course, complex the surgery becomes and the more risky it becomes. But it has its indications. Here's bilateral vertebral occlusion and a carotid occlusion. And this, in this case, was a large vein graft. Remember, I didn't say high flow. It's large vein graft. And to the PCA, and you can see the flow in it, 180 cc's, which is a normal flow of the basal. So this is a high flow bypass. But I don't say high flow because it's a big vein. I say high flow because I'm showing you with proof that it is high flow because the flow is being measured. This is another situation. Look at this here. Multiple symptoms. There's no flow in this basilar that you can see in the MR, but this man is alive. So obviously there is some flow. And if you do a special sequence with the NOVA low flow protocol, you see that the flow is actually there. Everything is open, but it's very, very low flow. -3, -9, -11. He's alive because of leptomeningeal collateral from the middle cerebral artery. So this is a subtemporal approach with an interposition graft from the ACA to the PCA, from the STA to the PCA. And you see here the PCA being marked. Right here, the third nerve. Like you've heard so many times from Juha, there's only one truth in life, right, Juha? That the PCA is above the third nerve and the SCA is below the third nerve. So it's a bypass from the STA to the PCA, but with a short interposition vein graft. This is a short interposition vein graft, and this here is the STA stump. And here's the bypass being completed. And here's the stump here between the STA, vein graft, PCA. It's a nice bypass because it's not as much flow as a big vein from the carotid. It's intermediate, 74 cc's. You see this bypass here, STA, vein graft, PCA, basilar. And the key here is look what happens to the flow. I'm showing you this yet another time. This is this oscillating mid-basilar flow, which is very dangerous. We call it an ominous flow pattern. Those are the patients that are hypoperfused, that have flow that goes up and down in this basilar. Same thing that I saw 30 years ago. And once you do this bypass, you fix this problem, the flow becomes a normal waveform and it does not go to zero anymore. This is how I do those bypasses now, just to not leave you with the impression that I do it subtemporal anymore. The better way is to do it pretemporal at about the P2, P3 junction, right around the third nerve. This is a much easier way and much less retraction. Last case, my favorite case. This man comes with VBI, bilateral vertebral occlusion, locked-in syndrome, which recovered because someone dropped his pressure and thankfully they recovered it. And he was sent to me for a bypass to the posterior circulation. Of course, I can do this bypass, but I also noticed that he is alive because he has flow through the right PCOM. Otherwise, he would be dead. But his right carotid right here has a very significant stenosis. So again, you see the PCOM. That's the flow through the PCOM, through the right carotid, but with a significant stenosis. So you see he has flow in his PCOM, 92, but not enough. 25, 13. It should be above 40, and the basilar is retrograde. So the flow goes up through a small carotid. You see the flow is 230 compared to 464 on the right. So I thought, what if instead of doing a bypass, I improve the flow in this carotid? Maybe it will improve, go down this way, and I don't need a bypass. So that's what I did. I did an endarterectomy. You see it looks better. And the proof is that the flow improved. You see now the PCOM has 145 cc's and the flow in the PCAs is normal. So the lesson here is that sometimes we can do a less invasive procedure if we think about the need for it and what flow to use. So I hope I showed you that the vertebrobasilar system is a wonderful system. We can understanding much better than the anterior circulation. Flow measurements in the posterior system with this NOVA software and the algorithm that we published has been shown. The only thing that's shown through prospective studies that low flow is associated with high risk of stroke. And we have, as surgeons and endovascular folks, we have many procedures that we can do based on the need of the patient, as identified by flow measurements. So I think it's a new frontier for us. I encourage surgeons to look into this as opportunity to help patients and as opportunity to advance yourself in a relatively unexplored domain in vascular neurosurgery. So I will conclude by once again reiterating my appreciation, admiration, and great fondness for Professor Ernest Niemi, who's an inspiration to all of us, and thank you all for being part of this experience.
Okay.
Thank
Juha,
you,
are there?
Fady.
Go ahead.
I'm there, but I don't get my picture there. So thank you very much, Fady, for your wonderful lecture. Very innovative techniques and good result. I especially like the case number 2, where you didn't give up. And this guaranteed many heroic, desperate operations, guaranteed the many years of life for the patient. So I think this lecture is open for discussion. Please go ahead.
Thank you, Fady, for your fantastic and very informative presentation. I learned a lot again. Actually, today we have around 1,000 neurosurgeons watched your presentation in the WeChat channel. Thank you. And it's very amazing because I didn't treat so many posterior circulation ischemic patients. It's very rare in in East China, because I main practice in the east part of the China, but actually it's quite not common in north of China. Yeah, they have a lot of posterior circulation ischemic patients in North China. Maybe because of the diet is more salty. And
well, it would be interesting if you give this some thought, Professor Shubin, because as everybody in the audience knows, not only you're an extremely busy neurosurgeon, you're the most busy bypass surgeon in the world, but you're every time I hear your talk, I see new ideas, and we all learn from you. So I'm glad to hear your comments, and I look forward to, once you have a chance to digest it more for us. As usual, when we meet, we sit down with a piece of paper and we talk about what to do next. Look forward to it. Thank you, Shubin.
Yeah, we don't notice. You mentioned actually the balance point is waving in the basal trunk. It's a very dangerous symptoms. Yeah.
And I think, I know you and I have talked about this, and I've seen how you're looking at the pressure gradient. I think we also do that in the anterior circulation. I think when we do a bypass, maybe sometimes there's too much flow in the bypass, and it shifts the oscillation of the almost stationary flow. You see it at surgery a lot of times. When you do ICG, you see the flow doing this. It's harder to determine in the anterior circulation because it's such a much larger system. Posterior circulation is more constrained and in a way easier to study.
It's a watershed.
Watershed, exactly.
Yeah, watershed.
Yeah. Great.
Thanks, Professor Fady. Hello, this is Victor Hugo from Mexico City.
Sure. Hello, Victor.
Wonderful lecture, an amazing cadaveric lab. Hope someday.
Your anatomical skills will be very appreciated there. We look forward.
Thank you, Dr. Fady.
Yeah.
Thanks.
We have a question from Mohammed Helmi, Dr. Okay, a great presentation. What are the measures you take? Let's see here. Where'd the question go? What are the measures you take to prevent hyperperfusion injury in such cases?
Yeah, great question. I have not included that in my talk. I've taken a number of measures into posterior circulation. I try to keep the flow below 100 when I do an acute bypass. Sometimes I have been able to control the flow by just lowering the blood pressure at surgery and measuring it until I get to the right number. Sometimes this was not enough, so I put a Silverstone clamp and reduced it for a few days and then removed it. Sometimes I put a little string inside the catheter and narrow it for a few days and then removed it. But that's a very good question. And in the acute stage for flow augmentation, we don't want more flow. My cutoff, it's empirical, but my cutoff is I don't want more than 100 cc's in the acute stage. Usually though, the blood pressure, if you measure flow, you can titrate while at surgery. You measure flow and you say, you find it's 250. You say, oh my goodness, this is too much. So you ask anesthesiologist to drop the blood pressure. And once you get the right number, you can say, okay, that's a good number. Let's keep the patient like that at this number for maybe 4 or 5 days. I think the experience of everyone showed that the autoregulation comes back usually within 24, 48 hours. And I don't think there have been any cases of hyperperfusion injury after 9 days. So you can choose, Shubin, maybe you can comment how long you want to worry and how long you want to keep the blood pressure. Would you care to comment, Professor Shubin?
Actually, I have a question for you first.
Yeah. Yeah, okay.
What about the timing of the acute stroke?
Yeah, again, this is completely arbitrary, But if the patient is stable, I like to wait a month. Why do I say that? It's because I used to do the bypasses with any time, and many years ago, I presented that, but I didn't publish it. The first 100 bypasses I had for flow augmentation, I had 5 hemorrhagic complications. 3 of them were actually fatal because I even used vein graft, and one of those patients had 250 cc's of flow. So just through retrospective univariate analysis, we found that number 1, flow greater than 100. Number 2 was bypass less than 1 month after stroke, and 3 is age over 70. So it's retrospective, biased, of course, data. But that since then, I've decided that that's what I will use based on my experience.
Yes, I agree with you. Normally, I wait 6 weeks after the acute stroke.
And in fact, if we look now at the data from neurology, any surgery after stroke, any surgery, if you do any surgery, some people say wait even longer, there's a risk of recurrent stroke. From any surgery, but of course we're trying to do surgery to prevent a stroke, so we have to decide the right time. We cannot wait too long.
You mentioned you did a lot CCA to vertebral artery bypass.
Yeah.
So would you do the preoperative balloon occlusion test for this kind of patient? Because you have to occlude the CCA for maybe 20 minutes.
Yeah, and you have to occlude the vertebral artery. So, so I was very worried about that. The first case, the very, very first case where I did that, actually I did it, I was so worried that I did it under hypothermic circulatory arrest because I was very worried of occluding the vertebral artery to put a bypass in. And Dr. Carney told me that in all his experience, he never had a problem. He said, do not worry, because the bypass does not take too long. This is usually a 20-minute bypass, and there's some collaterals. He said, don't worry. So I trusted him, and I never had a problem related to temporary occlusion. So it's a very good point, but I was very, very worried. And I do monitoring, of course. I do motor sensory monitoring, but it's never been a problem. Dr. Carney was correct.
Okay, that's a very important experience. Thank you.
Yeah.
Okay, Luis Lopez Ybor, you have a question and comment?
Okay, congratulations, Professor Fady Charbel, for your excellent presentation and excellent work. I am endovascular neuroradiologist. I trained in Paris, with Las Junias, also many people of France. And at the beginning, the first case to treat in the basilar ischemic thrombus in the basilar artery is with balloon technique. And in 2001, in the stroke center in Madrid, I treated about 150 stroke case endovascular rescue, and 20% of the case is by vertebrobasilar occlusion or pathology. And where is the evolution in this time? The evolution is the angioplasty with a stent or aspiration to remove the clot. Why is the main difference, in my opinion? The main difference is, see, you are stenosis, you are clot before the stenosis. But do you know, you don't see the clot in emergency situation. You don't see the stenosis. And the problem when you perform the angioplasty, you crash the plaque with the wall and you destroy more fibers in the brainstem. And this is the main point to discuss. And my question for you is, see, in one procedure, I have this situation. I remove the clot, and you are the small pass of contrast. I think it's better to perform or to discuss, to analyze, see, you are, what is the difference in the gradient of pressure, and it's preferable to wait, to stop in this part and to perform this bypass, because the lesion after angioplasty in the basilar artery, in the middle part, in the protuberancia, with the mesencephalo, is very, very complex situation to the patient. And this analysis, I think, is important to discuss with the neurosurgeon of you or another to what is the best protocol or guideline to treat this situation. What do you think about with my comment?
Thank you very much for this comment. This is a very, very, very important point, a bit because obviously you have experience. This is a key point, guys, what you just heard. So in all the studies that looked at angioplasty of vertebral, especially basilar, the intracranial VB system, what you heard from Professor Lopez Ibor is that there's a very high risk. So Sampras showed that this was a very big problem. And the problem is as you heard mentioned by you, which is that you're squeezing plaque material into the perforators, and especially the stent. And the stents today are not well designed for that. So your point is extremely valid. I think that the intervention should be just enough to reverse the hypoperfusion state and not push it. So we do not need to get the flow to be 500. We need to get the flow to be above 120 in the basilar and above 40 in the posterior cerebral. And 40%, 50%, 60% stenosis may be acceptable. 70% may be acceptable. We have many patients where you have 70% stenosis, but the flow is good. So you treat them medically. So your point is extremely valid. And I think your point is the reason why so many studies that looked at stenting of the basilar artery did not show results, Sampras being one of them, is because of this problem. And I think it should be based on some objective data. What is our goal? One, we want to open the vessel if it's completely occluded, of course, but how much? You can maybe measure the pressure gradient. I think it's better to measure the flow because it gives you a real number. And the reason I say measure the flow in the system is because we have validated this. This is work that's 20 years of work. We validated retrospectively and validated prospectively. The Veritas study was an observational study that's very difficult to do, that took 8 years to do because we took patients that had vertebrobasilar disease. We've measured their flow. Everybody was blinded to the result of the flow measurement, and we followed them over 1 to 2 years to see who will have a stroke, who will not have a stroke. Very, very important study. And this is how we validated that those numbers are predictors of stroke. So now it's the only thing that is proven this way that says if someone has flow below 120 in the basilar, below 40 in the PCAs together, according to this algorithm, they are low flow state, 22% risk of stroke at 1 year. Therefore, if your intervention has less complication than 22%, it would be reasonable. But on the other hand, if you take the exact same patient and their flow is okay, they only have 4% risk of stroke at 1 year. And with maximal medical therapy, this could be even less. It's hard to find an operation or an interventional procedure that has less than 4% risk of stroke at 1 year for the basilar system. So if we select the patient properly, I think we have a good answer. And your comment is absolutely right on, especially for some that may not have your experience in treating the system, that if you do too much, you can push, you can dissect the vessel, you can occlude the vessel. I mean, you know all that. And you push the perforators into occlusion. So thank you very much for this comment.
My second comment. I have time, John, a second comment.
Yes.
Okay.
Yes, go ahead.
Professor Fady Charbel. Another situation, you know, many neurologists discuss with the insufficiency vertebrovascular system. Spontaneous insufficiency vertebrovascular system. And the patient have imagine with MR or have whatever you want. And some neurologists discuss with me why not to open the partial stenosis of the vertebral, dominant vertebral, or why not you close the another vertebral, why not you change the flow. I think this discussion is not, for me, I don't agree with the neurologist because the symptom is not very, 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 very clear. But I understand the bypass is different work. The bypass of the insufficiency of the vertebrovascular system is the same of the bypass of the external carotid artery with the middle shaft artery. Maybe you change or you are more possibilities the flow. You are a case from this bypass in the chronic insufficient vertebrovascular system. You are a case or you work from this?
Yeah, I showed I think 2 or 3 cases of bypasses for this system. And I think the key is to demonstrate that it's a low flow state. Because if it's a low flow state, this is a very dangerous disease, 22% risk of stroke at 1 year. And it's not just a normal, irregular stroke. It's a posterior circulation stroke. So that means a very high risk of disability and death. And I think if we select the patient based on a low flow state, I think we have a clear conscience to do a flow augmentation procedure.
Thank you very much.
Okay, Doc, I think we don't want to keep you too long. And one last question. Hittai's Kumar asked, can we use a radial artery graft instead of a vein graft?
Yeah, you can. I think radial artery is a good choice. I use a vein graft because I have access to cadaveric vein grafts, so I don't have to make an extra incision on the patient. So it's easy to do and less trauma, but radial artery is perfectly fine.
Okay, very good. Okay, Juha, do you want to wrap it up, Juha?
Last
Thank you very
question.
much. Thank you
Last
very much,
question.
Subin.
Johan,
Of course.
Professor Charbel, you mentioned that you sometimes you directly anastomose the vertebral artery to the CCA, but you also mentioned that you sometimes you use vein graft. So what's the difference?
So it depends on what the anatomy gives you.
Mhm.
If it's short, if it's too short, you have to put something in between. But it's better, of course, it's better to do less anastomosis. So if we can directly connect it, but it's always short, so it has to be connected on the back wall. But sometimes there's just not enough length.
Okay, thank you.
Okay, thank you very much, Fady, for a wonderful lecture. Extremely skillful surgery, and this lecture certainly gives a lot of thinking, and we have learned a lot. So thank you everybody for discussions. Thank you Subin for translating. The same to Takashi-kon for translating in Japanese. And have a nice day or evening or night here in China. So thank you very much. Next week again, Friday, the same time.
Very good. Okay, we'll see
Bye-bye.
everybody next week.
Bye-bye.
Thank you, Juha. Thank you,
Bye-bye.
Ben. Thank you, Eric.
Thank you.
Bye-bye.
Bye-bye.
Shangala,
Bye.
bye-bye.
Okay, we stopped recording. Does anyone want to say hi to Dr. Charbel before he goes? Well, perhaps not. Well, okay. Okay. Does anybody want to say hi to anybody?
Well, hello everyone. Hello, Dr. John Bennett, Dr. Victor
Yeah,
Hugo.
hey, welcome. Introduce yourself first, Uriel.
Well, hello everyone. I'm Uriel Tagle Vega. I'm a fourth-year medical student here in Peru, and I'm the president of the Peruvian Student Society of Neurosurgery and Neurosciences. And I'm working with Dr. Bennett for running this neurosurgical TV students team in Spanish, Equipo Estudiantil, here in Latin America, for making more bridges between students. And if you
Tell us about the Victor's conference.
okay, here in Spanish language, we have two very great lectures. One that is going today of the Society of Neurosurgery in Ecuador, that it will be good. And the second one that we are organizing with Dr. Victor Hugo Perez Perez, that is called Neuroanatomy for Latin America series lectures. That is a course of neuroanatomy in Spanish with very, very high quality doctors. So I hope you can enjoy to us, you can join to us for making this change, no? It will be in the September 11 at 8 a.m. Mexico time, and it will repeat all the Saturdays since 10-11 of September.
Very good. Thank you. Thank you, Uriel. Does
Thank
anybody else have something to say? Hello, Jorge Salazar. It's his conference tonight. Hello, Jorge. Are you there, Jorge? Salazar, perhaps he stepped away. But he's the Ecuadorian head, one of the heads of that conference tonight. Let's see. Anybody else want to network? You have some people out there. There's Harshad's there.
Professor Mohammed Taker wants to say something. Professor Mohammed.
Oh, okay. Mohammed, go ahead, Mohammed. Mohammed Johadi. I'm having trouble getting him in. I don't know why. Let me see if I. Go ahead. Are you there, Dr. Muhammad? Perhaps not.
Harshad Parekh, nice to see you. What are you
Hi,
doing?
Victor. How are you? Good to see you.
Fine.
Always pleasure to see you. I look at your lectures and also diagrams which you are posting nowadays on various platforms. Superb work you are doing. Great to see you again. Yeah, great to see you. You are doing wonderful job.
Yeah, I'm trying to get the schedule because
Yeah.
Victor hopefully will do one in English, hopefully for the Chinese demographic. Let me just share the webcast that Victor's going to do starting September 11th with Uriel.
Yes.
September 11th at 8 a.m. Mexico time. There's 12 different weeks covering different parts of neuroanatomy. So and hopefully we'll have one in English soon. So you don't understand Spanish, right, Dr. Parekh?
Yes. Today's lecture was superb. Nice, very nice presentation. Very good, very well done. Great job.
Had you heard of Dr. Charbel before, Harshad?
No. First time I heard. Yeah.
Very quality neurosurgeon, huh?
Yeah, very quality. A lot of work he has done, and it seems to be very knowledgeable person. Yeah. Superb work. Yeah, superb.
Yeah, I'm glad Luis Lopez could come to give his neuro intervention interventional radiologist point of view.
Yeah. Right. Great. See you next week then.
Okay, very good. Okay, okay, very good. We'll talk later. Okay, Saeed and Uriel. So we're gonna close it up. Thanks everybody for coming.
Thank you, everyone.